Welcome to the debate. Picture this, if you will, a pediatric emergency room. It's 2 a.m. It's loud, chaotic, and right in the middle of it all is a terrified parent holding a lethargic toddler who hasn't kept any fluids down for 12 hours. This is the absolute bread and butter of pediatric medicine, gastroenteritis. But beneath this incredibly common presentation lies a fierce clinical controversy about the best way to rehydrate that child.
It's deceptively simple, isn't it? I mean, we're just talking about replacing lost fluid. It feels like plumbing. But the how matters immensely. On one side, you have the technological marvel of the IV pump. It's precise, it's controlled, it's immediate. And on the other, you have the biological marvel of the human gut.
And that really is the central tension we're unpacking today. Is the modern reliance on intravenous fluid therapy a triumph of safety and precision medicine, or is it an unnecessary medicalization that bypasses the body's own, highly effective absorption mechanisms? I'm the advocate, and I'll be arguing that when a child is significantly unwell, the IV is really the only way to guarantee safety, manage electrolytes, and prevent circulatory collapse.
And I'm the dissenter. And I'll be arguing that we have frankly become addicted to the plastic tubing. Based on data from the MSD manual and OHSU protocols, oral rehydration therapy, ORT, it's vastly underutilized. It's safer, it's physiologically superior, and when you combine it with modern antiemetics, it keeps kids out of the hospital.
Okay, so let's start with the stakes. We are not just talking about a thirsty kid here. According to the OSU figures, gastroenteritis accounts for over 1.5 million pediatric outpatient visits every year. When these children deteriorate, they don't just get dry, they get shocky. They get electrolyte imbalances that can cause seizures. My stance is rooted in the rigorous guidelines from the Royal Children's Hospital, the RCH, in Melbourne. They frame IV fluid therapy not just as water, but as a prescribed medication.
And I don't dispute the gravity of the condition. I mean, it's a volume business, but I dispute the default reaction to that gravity. The whole prescribed medication framework, it's useful for safety protocols, sure, but it creates a bias toward intervention. The MSD manual notes that ORT has a failure rate of less than 5% and has prevented over 1 million deaths globally per year. In developed nations, we tend to ignore this because we have the luxury of IVs. But just because we can cannulate a child doesn't mean we should.
But let's look at that luxury of the IV. In a high-stakes environment, luxury is safety. When I have a child who is lethargic or refusing to drink or vomiting, the oral route it's a gamble. The IV is a guarantee. The RCI-CRH guidelines are obsessive about safety for a reason. They recommend a very specific fluid, sodium chloride 0.9% with glucose 5%. Now, this matches plasma concentrations to prevent things like cerebral edema, while ensuring the child doesn't become hypoglycemic. When I hang that bag, I know exactly what is going into that child's bloodstream. When you hand a parent a cup, you're hoping for the best.
See, that word hoping? It implies that ORT is some sort of folk remedy. It's not. It is high-tech physiology. The MSD manual explains this beautifully. The gut is not just a passive sponge. It uses a mechanism called sodium-glucose co-transport. So think of it like a turnstile at a stadium that needs 2 tickets to open. You need 1 molecule of glucose and 1 of sodium. When they hit the receptor together, they unlock the gate, and water is dragged right through with them. This is an active pump. It works even when the child is sick. By using an IV, you're bypassing a system that evolution spent millions of years perfecting.
Evolution is great, but evolution doesn't care if the child spends 3 days in the hospital or goes home in 4 hours. And frankly, evolution assumes the mechanism is functional. The co-transport mechanism is fascinating, I grant you that, but it has a fatal flaw. It requires the child to actually swallow the fluid.
Which brings us to the real barrier, doesn't it?
Exactly. Vomiting. You can have the perfect molecular ratio in your cup, and we can argue about that ratio later, but if the stomach is ejecting everything, that transport mechanism is useless. The IV bypasses the stomach entirely. It rests the gut. It breaks the cycle. When you have a parent covered in vomit,
They don't want a lecture on co-transport. They want the vomiting to stop and the hydration to start.
And that is the traditional view. And I understand the emotional weight of it. But it's outdated. The OHSU protocols and, frankly, modern practice everywhere have introduced a game changer that completely alters this debate, ondansetron, or Zofran.
It's a useful drug. Sure, I use it.
It's more than useful. It's the cornerstone of the whole no IV approach. The OHSU protocol is explicit. If a child is vomiting, you do not reach for the needle. You reach for the ondansetron ODT, the little dissolving tablet. You give a weight-based dose, anywhere from 2 milligrams for the little ones up to 8 for the larger kids. And then, and this is the hardest part for high intervention doctors like yourself, you wait.
That waiting period is exactly where the risk lies.
It's 20 minutes. You wait 20 minutes for the receptor blockade to take effect. Then you restart oral hydration. The data shows that children who get ondansetron are significantly less likely to be admitted and significantly less likely to need an IV. The vomiting barrier isn't a wall anymore. It's a speed bump.
I'm glad you brought up the OHSU protocol, because if you read the fine print, it actually supports my caution. It has specific failure criteria. If emesis persists after a second dose, or if the child refuses fluids for more than 30 minutes, you must escalate. My concern is that in a busy ER, or with an inexperienced clinician, this try-and-see approach can drag on. You give the Zofran, you wait 20 minutes, they vomit, you give another dose, you wait. Meanwhile, that child is becoming more acidotic, their perfusion is dropping, there is a point where persistence becomes negligence.
I agree there is a limit. The OHSU protocol isn't infinite. But let's be honest about where that limit sits. You are describing a child who is crashing. I am talking about the 95% of kids who are miserable but stable. For them, the IV is actually the more dangerous option.
Dangerous? That feels like hyperbole. We insert millions of cannulas.
Is it hyperbole? The RCH guidelines themselves, your source, warn about fluid overload and edema. We see swelling of the eyes, periorbital edema, swelling of the genitals, the lower back. I mean, when you pump fluids directly into the vein, you are force-feeding the kidneys. If you miscalculate the rates, or if the child has high ADH levels, which is common in stress, nausea, and pain, they retain that water. They get puffy, they get hyponatremic. The gut doesn't do that. You cannot overload a child with ORT because the gut has a satiety feedback loop. They stop drinking.
That is a valid physiological point regarding ADH secretion, but it ignores the reality of severity. We need to define our terms here. The RCH guidelines draw a hard line at shock. So if a child has a heart rate of 180, cool peripheries, mottled skin, and a cap refill time of 4 seconds, do you still hand them a cup and tell them to sip?
Absolutely not. If they're in shock, the debate is over.
Okay, so we agree on the extremes.
We do. If there's circulatory collapse, you need immediate volume expansion. 10 to 20 mils per kilo of normal saline as fast as you can get it in. That is resuscitation, not rehydration. No one is debating that.
Right. But the danger zone is the transition, the child who is moderate, but sliding towards severe. The dehydration score tables in the OHSU material are great, but clinical signs are subjective. A child with dry mucous membranes and decreased activity is a score of 3 or 4, moderate. But how fast does that become a score of 6? My argument is that establishing IV access in that moderate phase provides a safety net. It allows for rigorous monitoring that you simply cannot get with oral therapy.
But that monitoring creates its own pathology. This is what I call vampire medicine.
Vampire medicine? Explain that.
You put in an IV. Now you feel obligated to use it. RCX guidelines for IV therapy require weighing the child daily, checking input and output every 12 hours, and drawing electrolytes every 24 hours. You're poking the child, waking the child, stressing the parents. You are keeping them in the hospital to monitor the treatment you started. Contrast that with the OHSU discharge criteria for ORT. Demonstrated ability to tolerate fluids, parents instructed on care, stable vitals. That's it. They go home, they sleep in their own bed.
And what if they go home and seize?
That's fear-mongering.
Is it? Let's talk about hyponatremia. This is the specter haunting pediatric fluid management. In the old days, we used hypotonic fluids, solutions with less salt than the blood. We saw cases of cerebral edema, brain swelling, because water rushed into the brain cells. Now, the modern RCH guidelines emphasize using isotonic fluids, 0.9% saline, with glucose to prevent this. But even with oral rehydration, if a child is just drinking water or apple juice, fluids with no sodium, they can drop their sodium levels dangerously low. An IV protocol allows me to control the sodium input down to the millimole.
Okay, but you're conflating oral rehydration therapy with drinking whatever is in the fridge. You are absolutely right that apple juice, ginger ale, sports drinks, they're dangerous. They have too much sugar and almost no sodium. They actually cause osmotic diarrhea. They pull water out of the body because the gut tries to dilute that massive sugar load.
Exactly. And that worsens the dehydration.
But that isn't ORT. The MSD manual specifies the WHO formula or, modern commercial equivalents like Pedialyte. These have a specific osmolarity. They have 75 millimoles of sodium and 75 millimoles of glucose. It is a precise prescription, just like your IV bag. If you use the correct solution, the risk of hyponatremia is negligible because the gut regulates the uptake. The risk of hyponatremia is actually higher with IVs because you're bypassing that regulation and relying on your own calculation of the infusion rate.
Theoretically, yes, if the child drinks the perfect solution. But practically, have you tasted those solutions?
They are distinctly salty.
They taste like sweat mixed with syrup. Getting a sick, nauseous 4-year-old to drink a liter of that it's a battle. And who fights that battle? The parents. The OHSU protocol talks about empowering parents, but at 3 in the morning, parents are exhausted. They're scared. Sometimes the most compassionate thing we can do is take that burden off them. An IV allows the child to sleep, the parents to sleep, and the hydration to happen automatically.
I understand the compassion argument, but I think it's misplaced. Is it compassionate to hold a terrified child down to insert a needle? Is it compassionate to admit them to a noisy ward for 24 hours? The OHSU workflow accounts for the taste issue and the volume issue. It's called pacing.
Walk us through that, because pacing sounds like a euphemism for begging the child to drink.
Under 10 kilos, you give 5 milliliters via syringe every 5 minutes. That's 1 teaspoon. Even a nauseous gut can handle 5 milliliters. You do that for an hour, you've given 60 milliliters. That's a significant amount for a baby. For larger kids, you scale up to 10 mils or even 30 milliliters every 5 minutes. It requires patience, yes. It requires a nurse or a parent to sit there with a timer, but it works. And it teaches the parent how to manage the illness at home next time. If you just fix it with an IV, the parent leaves thinking, only the hospital can fix my child.
That is a fair point on parental education. But I want to circle back to the glucose issue. The RCH guidelines are very specific about including 5% glucose in maintenance fluids. This isn't just for energy, it's to prevent ketosis and hypoglycemia. Small children are very prone to this because they have tiny glycogen stores in their livers. If they stop eating, they run out of fuel fast. If a child on ORT refuses to drink for 4 hours, their blood sugar drops. That makes them more lethargic, which makes them drink less. It's a death spiral. An IV with dextrose stops that immediately.
It does, and checking glucose is non-negotiable. We agree on that. But ORT solutions contain glucose. That's the G in the cotransport. If they are drinking the solution, they are getting the sugar. The death spiral you describe is real, but it's a sign that ORT has failed. And if it fails, we escalate. I'm not saying never IV. I'm saying IV is the backup, not the starter.
I think my hesitation comes from the overlap cases. The kids who aren't quite shocky, but they look terrible. They're lethargic, maybe a bit tacky. You try the Zofran, you try the syringe, they spit it out. You try again, 2 hours have passed. And that time I could have had an IV in, the child rehydrated, and the labs back. Efficiency matters in a crowded ER.
Does it? Or does perceived speed matter? The MSD manual cites studies showing that overall time to discharge is often shorter with ORT. And why? Because you don't have the admission paperwork, you don't have the wean-off fluids phase. Once they drink, they go. The IV feels faster because the bolus goes in fast, but the episode of care is often longer. We are prolonging the stay to justify the intervention.
Let's talk about the red flags, though. The RCH guidelines have a list of conditions where they explicitly say, do not just push fluids. Things like renal failure, cardiac issues, or pre-existing electrolyte abnormalities.
Agreed. Complex kids need complex care. If the kidneys aren't working, you don't flood the gut.
But also, severe abdominal pain. A child with a twisted bowel or an appendicitis can look just like gastro. If you were just focused on getting the Pedialyte in, you might miss the surgical pathology. The process of placing an IV, getting bloods, getting a lactate, it forces a diagnostic pause. It makes you look closer.
Not as a double-edged sword. Yes, it forces a pause, but it also anchors you. Once the IV is in, you treat the numbers. Oh, the potassium is 3.4, let's add KCl. Oh, the chloride is a bit high. You start treating the spreadsheet instead of the child. With ORT, the primary metric is, does the child look better? Are they playing? Are they making urine? Those are the metrics that actually matter for recovery.
I suppose it comes down to what you fear more. I fear the missed deterioration. I fear the child who goes home and comes back in shock. I fear the electrolyte imbalance that triggers a seizure. The IV is my insurance policy against those catastrophes.
I see why you think that, but let me give you a different perspective on fear. I fear iatrogenic harm. I fear the infection at the IV site. I fear the fluid overload causing edema. I fear the medicalization of a natural process. The body knows how to heal from a stomach bug. We just need to get out of the way and give it the tools, the salt, the sugar, and the Zofran.
And I'm just not convinced by that line of reasoning because it places too much faith in a system, the gut, that is currently under attack by a virus. But we have covered a lot of ground. So where do we land? We have the listener standing in that ER. They have the lethargic child.
I think the synthesis is in the triage. We need to be rigorously honest about the dehydration score found in the OHSU material.
I agree. You need to look at the table. Is the child thirsty and restless? That's moderate. That child gets the cup and the Zofran. Is the child limp, cold, and sweaty? That child gets the cannula.
Precisely, and we need to stop treating the thirsty kids like limp kids.
And we must stop treating limp kids with a syringe.
Deal.
I also think the takeaway on fluid choice is critical. If you are going to use the IV, do not use the old hypotonic fluids. Use the RCH standard, 0.9% sodium chloride with 5% glucose. It is the safest bridge.
And if you are using the gut, use the right fluid. No ginger ale, no apple juice. 75 sodium, 75 glucose. Respect the chemistry.
And on Dancitron, it really is the pivot point. If you aren't using it, you are fighting with one hand tied behind your back. But remember the rules. Wait 20 minutes. Don't rush it.
It demands patience. That's the hardest thing to prescribe in an emergency room.
It is. But sometimes it's the most effective medicine.
And check the glucose.
Always check the glucose, even if they're drinking. You do not want to miss a hypoglycemic child because you assumed the Pedialyte was enough.
A finger prick is a small price to pay for peace of mind.
This has been a fascinating look at a daily dilemma. It forces us to balance our trust in technology with our respect for physiology.
It's the classic struggle, control versus nature.
We encourage you to pull up the RCH and OSHU guidelines linked in the show notes. Look at the red flags. Look at the failure criteria. The art of medicine is knowing when to switch from one protocol to the other.
Thanks for listening.
Trust the gut.
But verify with the vitals. Thank you for joining the debate.